Thank you for the warm welcome. Good afternoon, ladies and gentlemen. I'm really happy to be here. Thank you for the invitation. I'm a great fan of this kind of initiatives that enhance interdisciplinary understanding and interaction. I think at the end of the day, it makes us all perform better at our work. So when Gеorgia came up to me with the title of today's talk, I thought it was just a question, so my answer was this one, this sort, like we would like to know anatomy. Of course, I'll try and elaborate a little bit on that, but I'll keep it short. We want you rested and alert for the upcoming very important talk by Dr. Olsen. So I have to start out by stating that radiology is one of the faster evolving medical disciplines, probably because it absorbs more than any other discipline all the technology advances of 21st century, which means that now we're equipped with X number of detector scanners and X number of Tesla MRIs, fancy ultrasound devices, advanced software, and the truth is that we're spoiled by technology because we have all those great high fidelity images, and the requirements are really high for high fidelity reporting too. And the truth is that we go very well prepared into surgery because of all these high quality images, and the end result is that nowadays we hate surprises. We very seldomly go in surgery and come across intraoperatively of some kind of nasty surprise. And I don't mean to imply that we hate the challenge of a good intraoperative surprise, but we have a good reason. And the reason is that we can plan surgery. That means that we can plan from minor details like incision type choices and placement, precise placement, all the way to having a dissection plan even before we go into surgery. And moreover, we can plan on resources. If there are specific difficulties and challenges foreseen, we can plan on specific special equipment that we might use, or having available other subspecialties that could give us could lend us a helping hand in case that we need it. All those have, the result of all those is that we can have the best possible result, oncologic result, and of course that means greater patient safety. So what we need to know, as I usually say, I want you to report calm. That means we need to know consistency of the tumor, anatomy of the tumor bed, lymph node disease, and metastatic disease. And the question that came up even discussing earlier with Dr. Olsen is, well, you are a trained surgeon, you are a 21st century surgeon, you're supposed to be able to see for yourself. And that's true. We are supposed to be able to look at imaging and understand imaging, but it's very hard for us to keep up with technology, so we're not always aware of all these great options available for each case. And we still don't have your training. I mean, you still are the experts. Every time that I questioned our radiologist, I paid the price dearly, so I don't dare to do it anymore. So going back to calm, consistency, is it cystic, is it solid, is it mixed type of tumor? Has it bled in its substance? Is there a hematoma that we need to involved in our resection, and how vascular the tumor is? Then anatomy with capital A, space and boundaries, so that we can orient ourselves and realize which place are we talking about in 3D, and is it a well circumscribed tumor, or we have a loss of plane of dissection and places, and which are those places? And of course, relationship, and above all, relation to critical structures. Does it envelope, push, or infiltrate those critical structures? Last but not least is the anatomy distortion. It's very important for us. You know, as surgeons, just like pilots, we like to navigate by landmarks. In that case, we're talking about anatomic landmarks. Or if those landmarks are displaced, then we might get lost. So we need to know about this displacement. And here's a good example here. We're talking about a neuroblastoma, left upper paravertebral neuroblastoma. And what's the effect on the aorta? It has rotated the aorta to the left. That means that the IMA is taking off from the left. And how do we dissect those tumors? We split the tumor anteriorly, and then we start dissecting circumferentially. If I split the tumor anteriorly and I don't find the IMA where I expect it, then it's going to be a little bit messy dissecting left and right, hoping to find it, because we need to control those major bleeders before we start dissecting more. Then we go to lymph node disease, whether there is pathologic lymph nodes, either regional or distant. In sometimes we need to go after those lymph nodes. The same goes with the metastatic disease. If we have implantation in the peritoneum, or we have liver mets, we might need to go after those lesions. And if there are distant metastatic disease, we might even decide not to go to surgery, of course, after having discussed that with our oncology partners. So I would like to say a couple of words for the most frequent solid tumors that we encounter in pediatric oncology. First, Wilms. You, of course, need to report on contralateral disease, whether that's nephroblastoma per se or nephroblastomatosis, because this might change the plan of surgery. It might need to be not a resection of the tumor and the kidney, but a nephron-sparing surgery. We need to know about any thrombus, tumor thrombus floating in the renal vein, especially if it's floating also in the IVC, and how far up the IVC does it go? Is there a possible rupture we should know about, and where is it located? Because we need to be more careful and try and resect the ruptured tumor along with the main tumor. And something that I came to appreciate recently, it's in relation to the adrenal gland. Recently we had this really humongous right upper kidney pole tumor. And you know, when it's an upper pole tumor, we need to resect along with the rest of the kidney, the adrenal gland. In that case, the adrenal gland was reduced to a thin film of tissue hidden right under the IVC, the upper IVC. I was warned about that, so I knew where to look for the adrenal gland instead of dissecting around. Useful information. Then going to Wilms, bilateral Wilms, we need to know the relation of the tumor, each one of those tumors, because the surgery in that case is nephron sparing, to the pelvic calyceal system and the renal hilum. Of course, that figures, I guess, but what I would suggest also is to do a urography in those cases so that you don't come up across surprises like this one. This is on a petaloid kidney. The left side, we're planning to do nephron-sparing surgery, and this is what we found intraoperatively. So what you see is a triple pelvic calyceal system. Each one of those systems, they have their own partial ureter, and they all come together and they form a proper ureter. So, and what do you know? The tumor was sitting right under this confluence, and we had to resect that. Neuroblastoma, again, anatomic space. Is it chest? Is it abdomen? Is it paravertebral? Is it upper? Is it lower abdomen? Mainly, we would like to know whether the tumor actually crosses the thorax. When we're talking about the thoracic tumor, whether it crosses to the abdomen. There is always a big debate: has it crossed or hasn't, or it hasn't? And of course, you all know that the neuroblastoma has this very bad habit of encasing any type of tubular structure it encounters. So we need to know the relation to vessels. The esophagus when we're talking about thoracic neuroblastoma, and the ureter when we're talking about lower abdominal neuroblastoma. All those, of course, they are included in the imaging-defined risk factors. so you need to report on those anyway. This is a nice case also of left upper neuroblastoma, and you see that the aorta has been encased by the neuroblastoma, the IVC has been flattened out, but what is interesting is that the renal artery is crossing the neuroblastoma. Also the renal vein is crossing, but it's not just one. There's a lot of collateral disease, collateral circulation. So before you go into surgery, you need to know about this collateral circulation before you run into trouble. And sarcomas, a wide range of tumors, bone sarcomas, soft tissue sarcomas, rhabdo, non-rhabdo. We need to know the space in the compartment, especially when we're talking about soft tissue sarcomas of the limbs. If it's crossing the compartments, then we have totally different type of surgery. If it's infiltrating the aponeurosis, we're also having a different type of surgery, so we need to know that. In rhabdomyosarcomas, we need to know about the extent of urinary bladder wall infiltration, and we need to know the boundaries to vessels and nerves. In sarcomas, we need to have a nice margin between the tumor itself and the nerves and the vessels. If we don't have that margin, then we need to plan to have available other subspecialties and plan on brachytherapy catheters. So it's a very important piece of information, and of course lymphatic disease too. We need to go after pathologic lymph nodes, and in soft tissue sarcomas in non-rhabdos, and in rhabdo, especially in paratesticular rhabdomyosarcoma, we need to go after pathologic lymph nodes of the para-aortic group of lymph nodes. Well, I don't need to say much about hepatoblastoma. You have a front sheet to treatment plans. You need to pretext the tumor and inform about hepatic portal vein involvement and other things, so that the therapeutic can be formed. So in conclusion, I would say you should report calmly if possible, because we do value your expertise. We try to be a bit of radiologist. Meetings like that maybe will help you become a little bit of surgeons. Of course, you're all welcome to join us in surgery whenever you have the time and have a look live of what you see on screens. Maybe it would be enlightening for you too. And yeah, let's work together. Thank you.